welcome. This is a webinar that we're doing on an international clinical perspective on what we call Lyme disease. Although it's called many things in many places and in different points in history, it was called many things. I'm a psychiatrist in New Jersey, and I became interested in this because I kept seeing the late stage cases. And it seems when there's a failure in our healthcare system, these people often referred to psychiatrists. Sometimes they're told it's all in your head, it's psychosomatic or other reasons. And I kept seeing more and more of these patients. So it forced me to try to understand this better. And it opened up a lot of questions that still remain unanswered. And my co-moderator is Dr. Greenberg. And do you want to introduce yourself? That
Okay, I'm Dr. Rosalie Greenberg. Thank you, Dr. Bransfield, by the way. And I'm a child and adolescent psychiatrist, and I work with a lot of youngsters that have infection-related psychiatric issues. And the one thing Dr. Bransfield and I and our colleague, Dr. Mao, we just wrote a paper on microbes and mental illness. And it's very clear that a significant amount of mental illness is probably related to infectious causes. And that's especially true in the area of Lyme disease. As Dr. Bransfield said, it has many names, and other tick-borne infections. In the United States, almost 500,000 new cases of Lyme disease are diagnosed each year. But it's not just an American problem. One study found that 14% of the world's population is seropositive for Lyme, the Lyme bacteria. Now, that doesn't mean they have the infection, as we know, but that does mean exposure, which makes this a very important issue worldwide. And it's an issue that I think we all want to collaborate about because there's so much more we need to know diagnostically and therapeutically. And hopefully this is the beginning of that dialogue. So
now this is a dialogue on an international perspective. So what we particularly looked for were experts that had an international perspective, that had experience in working with patients from different countries, and particularly had extensive experience with the long-term responsibility of caring for these patients. And we felt that those would be the experts who would truly understand this, who being on the front line. So let's go around and maybe each of you could introduce yourself and describe a little bit about your practice. We could start with Cecile. I think has been working with infectious disease since the age of 6. Was that correct, when you worked in your father's lab?
And that's correct.
You've been doing it since?
Yes. I started with feeding the animals with specifically sugar, magnesium, and glutamate. Then I was allowed to take their temperature that was shooting up after those feed, and then I had to splenectomize them, which made for me a surgeon, because to splenectomize a rat and a guinea pig is not that difficult, but a chimpanzee was difficult. And then I became a surgeon, and to finish my surgery, the law in that country was, in my Belgian country, was or to go to Switzerland or to South Africa. I came to South Africa, ticket going back, and I stayed, not because of the politics, rather because of the weather. And having children was difficult to carry on with surgery. So I went to my first love and knowledge of medicine, which was chronic infectious diseases. And we, with the help of my father, we opened a big lab here on chronic infectious diseases, meaning Lyme, Rickettsia, Mycoplasma, Chlamydia, Toxoplasmosis, Brucellosis, Bilharzia, Bartonella, less Babesia. I see that a lot of people are talking about Babesia now. According to my father, Babesia would kill you or would be killed by you. Babesia is always with a big anemia, presents with a big anemia and hematuria, which now we don't. So I don't know if you've been positive for Babesia, you will be always positive. If you've been positive for any germ, you stay positive. So I don't know chronic Babesia. I don't adhere with
Okay.
that.
We can go into that more. Now, your father was quite famous as an infectious disease doctor in Africa, and you grew up
Yeah,
working with him and Nobel Prize laureates visiting him and working with him, and so you had quite a background in working in that arena in
that's
South
correct.
Africa and in those other countries, as I understand.
Well,
Correct?
no, it was in Congo, and after that, age of 6, we went to Paris, where he joined the Pasteur Institute, and then 5 years later, he opened the Tropical Institute in Antwerp.
Okay. All right. Now, and then Dr. Lambert, you're in Dublin and Ireland. You have quite a background too. In fact, I think you have some background in Africa, and you've seen a large number of patients, correct?
Right. So I'm an infectious disease expert, and my training was, well, I'm Scottish born, living in Dublin, but I did most of my training in America, and I spent a bit of time in Haiti. I had research projects in Africa, Brazil, Caribbean, India. So mostly related to HIV, because when I joined infectious diseases, HIV was a major disease. But subsequently, I spent the last 18 years in Dublin, Ireland, with intent to return to Scotland someday. And I see all infectious disease. So I work in the public hospital. I have a public clinic. I started seeing private patients with tick-borne infections just in the last 7 or 8 years in Ireland, because nobody else was. But my scope of practice is everything from COVID, long COVID, tuberculosis, schistosomiasis, toxoplasmosis. So I do all infectious diseases, but I think the most challenging part of my practice really is the challenges of tick-borne infections, chronic infections with Lyme, and also now long COVID, huge challenges and huge populations out there with very little support and treatment, which is a challenge.
Okay. Now, Dr. Jemsek, you've seen a large number of patients, and you've seen a fair international population working in Washington, D.C. with some of the diplomats and people that come to you. What's your experience?
My experience is that I'm a good old American boy. I've stayed within the shores of America. No such adventures for me. However, I was exposed to some excellent educators as I grew up. George E. Jackson, who was one of the founders of the IDSA and was the chairman for the Journal of Infectious Diseases. I knew him in medical school. I knew various people in my residency, and then I got a fellowship at Baylor at Texas Medical Center in Houston. And I was just totally convinced that this was the most marvelous area to be in. And prior to that time, there have been smatterings of HIV here and there. You know, what was this illness that was coming about? I settled down in North Carolina after I finished my fellowship, and ended up seeing the first case of HIV, what was to be known as HIV, in 1983. And after that, I became obsessed with doing HIV. In fact, my partners were always chastising me about, you know, all you do is HIV. This whole room looks like HIV. It looks, and I just tell them to go to hell and leave me alone. But and it went on from there, and I got involved in multiple clinical trials, learned a complex illness, and became very much more devoted to it. But I must say, and I don't know if anyone shares these feelings, after having started when I did, after the killing fields came in the early 90s in the US, I was exhausted. I was mentally exhausted. And I didn't know if I could do it much longer. I've been doing it 12 years, up, you know, lots of nights, you know, seeing very sick people, very disenfranchised individuals for the most part. and not much help from my fellow physicians in the area, and in fact, a lot of disdain for what I was doing. And I was thought as being a little strange. People didn't want to associate with me because I was taking care of patients with HIV. So I ended up setting up a smaller clinic in around 2000. It was supposed to be an HIV clinic, and one day a young lady walked in and said, "Do you treat Lyme disease?" I didn't. I said, "Well, of course I treat Lyme because when you get out of school and you've been out for a few years, you're really cocky, and you think you know everything, and of course you think you do, but you don't." And one of my precepts is, let's get the nobility of medicine back, and that means by working and by being humble and learning. Because medicine is learned through patient interaction, and I believe very strongly in that. And I've seen the deterioration of American medicine to the point that we're just, we're puppets on the string held by hospitals and insurance companies, and we're very confined in what we can do. And I think as I got into Lyme disease, and I learned that I was an idiot because I had said those things. I got into it and I thought, oh my God. And so the internet had just come around and the word got out that there was an infectious disease doctor north of Charlotte who was seeing patients with Lyme disease. And then our phone lines blew up and people would come in. I said, "Where are you coming from?" I said, "We're an HIV clinic." And they would say, "Well, we heard you treat Lyme disease." And I was going crazy because I didn't understand the internet and what it could do. And at any rate, one thing led to another. And after a year or so, I became enamored with the illness because having done HIV medicine for 23 years and worked very hard at it, I knew these people were sick. There's no room for hypochondriasis in our patient population. They just don't have it. Or if they do, it's few and far between. So I got on I started doing my own evaluation, and one thing led to another, and I've ended up following and seeing over 15,000 patients in the last 20 plus years. I'm now in Washington, D.C. I'm 4 blocks from Uncle Joe Biden down the street, and we're very happy here. We have staff of 20. We see about 40 new patients a month, and several hundred patients follow up on several hundred patients a month. And I'm very interested in continuing my career in doing exactly this. I see this as very, very exciting and very challenging, not only from a social but a political and medical community point of view. So I'm looking forward to working with my colleagues in France, Germany, and Ireland. I know Jack Lambert, but I haven't met Cecile. I don't know. I don't know Miss Dr. Christian as well. So so here I am, and in my practice I have a research personnel. And I've given them a challenge to let's do some clinical case reports at the very least, because like some of you, I've been battered by the medical board system.
Do you know this one?
Yes, I'm familiar with that.
Yes.
It's Frenchman, yes.
Luc Montagnier, that was the Nobel Prize for HIV.
Yes. And he used to visit you in Africa, right?
He used to visit me a lot, yeah.
Yes.
That was my husband, that was him, yeah. So I was working with Chronimet and Legrand, 2 French groups on chronic infectious diseases. And he was the boss of it, but he's not there anymore.
But a lot of us have that background. Anything more you want to say, Joe? And I want to get to Karsten.
No.
Okay.
Thank you.
Okay, Dr. Karsten Nicholas, why don't you give your background? And you're the MD, PhD in the group here. with a immunology background, and you've had a experience running a big program in Europe where you saw a lot of people in your Augsburg clinic that I once visited. Okay.
No, that's correct. First of all, Rosalie and Bob, thanks for inviting me to the webinar tonight. I'm very excited to be present and to give you a bit about my background. So my name is Dr. Carsten Nicholas. I'm a German doctor. I was trained in the south of Germany, first in Regensburg, later on in Munich, where I became very interested in research, specifically focused on transplant immunology. This I did in parallel to my medical training for at least 6 years. Later on, I did my PhD in immunology. I worked in several hospitals in the south of Germany, in Munich and in Augsburg, which was at that time one of the biggest clinics in Germany with more than 3,000 beds. After a couple of years, I got fed up working in a clinic, and I decided to make something different. And I opened my first practice, a family practice, after being trained in surgery, internal medicine, pediatrics. And I was never aware that I lived my entire life in high endemic areas in Germany. And I have to say, during my medical training and also afterwards until 1990, I've never had any contact with Lyme or with one of its co-infection. That happened more randomly when I opened my practice, as I said, in one of the highest endemic areas. So, and right from the first week after opening the practice, I had to deal with Lyme patients. It was quite challenging because there was not much where I could rely on. So in those early days, and I always tried to do my very best, and seeing more and more patients over the years in the 90s. So I've noticed that none of my colleagues in the surrounding had any interest. And as I said, it was very challenging to learn more and to find good solutions for my patients. And probably I'm one of the pioneers in Germany. There are probably not more than 10 doctors focused on Lyme disease. That has changed a lot meanwhile. So learning by doing, at the beginning was more empirically. Later on, so from the mid of the 90s, first organized conferences had happened in Germany. So in Munich, when I first met some international colleagues, specifically from the US, with some more options to learn a bit. And I became fascinated and passionate for that medical field, which I am now in for 34 years. I've treated around about 28,000 patients from over 80 countries worldwide. And in 2006, I decided to open the first clinic for tick-borne diseases and its co-infection in Augsburg, which became right from the beginning a very successful thing. So we have treated nearly 30,000 patients in that clinic. Unfortunately, the clinic had to close in the pandemic based on the travel restriction and the complete lockdown. And it was quite challenging to have the staff with with nearly 50 people without seeing any patients anymore. But I'm still focused, and the clinic in Augsburg was unique in that way that under one roof we had everything. So starting with diagnostic, we had our routine lab specialized in all diagnostic tools which are available to diagnose infectious diseases. We had the normal consultation in a practice. We had a day clinic to take care more intensively for patients. We had our own rehab center because in Germany, the most common strain is not Borrelia burgdorferi, it's Borrelia garinii, and some other strains causing serious forms of neurological issues. So I became very interested even to develop programs, rehabilitation programs with best physiotherapists and other specialists to get the best rehab for these very serious ill neurological patients. So some of them, as of now, have presented pictures like MS, ALS, and so on, or sitting in wheelchairs with serious forms of paresis. And this is where we became very specific in. With some delay, a couple of years later, we introduced also our own research center, very much focused on development on new types of diagnostic. And I was lucky to get twice a very big funding with other researchers from other parts of Europe to develop new test systems. The funding was from the European Commission. And we were very proud about that because we finished successfully. And yeah, I'm still in the field. I'm not seeing anymore so much patients. So I see it at the moment more important to train doctors all over the world in that field. And this is what I'm actually doing. Most of the time I'm living here in London. But I'm still seeing and treating patients, and that is I'm doing most of the time out of Germany, where I'm still running a practice.
Thanks. Okay. Now, if we look at it, we're thinking of three emerging diseases where we see, or emerging awareness. We see Lyme, tick-borne disease, we see COVID, and we've seen HIV. And but also there are three conditions with global impact. And there may be regional differences, like particularly tick-borne disease. There's certain strains in one area, but not in another area, different patterns, and then there's different healthcare systems. How would you compare? Are the patients all that different from different countries, or is it more the healthcare systems are different, where some healthcare systems in different countries are easier to navigate than others? Are some healthcare systems, I don't know if that went through, but are some healthcare systems in different countries easier to deal with than others? Any thoughts on that from any of you?
Yes, but it's not really the healthcare, it's the knowledge of the doctors, the education of the doctors. The doctors are not aware of those things. They rather treat the end product than the root. So when you come with multiple sclerosis, they've got a treatment. With rheumatoid arthritis, they've got a treatment. With epilepsy, they've got a treatment. They don't see where it comes from. They don't want to go and see there. They stay on the top, on the results. And they've got medicine for everything. And they try to stabilize the end product rather to stop it, to stop its development. And that's why it doesn't work.
Yeah, you're absolutely right. But, coming back to the questions, I guess there are definitely some countries where it's very hard as a patient or as a doctor to deal with, to treat Lyme. So I can only talk best here about the condition in Europe. So from a patient's perspective, I guess the hardest places to live are in Scandinavia or in the UK. There are many other countries where it's much easier now to get access to good treatment. I have to say, regarding the healthcare systems, there are also huge differences. So in some countries, tick-borne diseases are definitely better accepted and noticed than in other countries. And here I can specifically speak for Germany. So Rosalie mentioned at the beginning in her introduction. So in the US, we have actually around about 500,000 new patients. So the newest numbers from 2022 in Germany had officially reported 320,000 new infections with Lyme, which had been treated by German doctors. So these are not the statistics of the health department. These are based on data from all public insurance companies, by the way. So Germany has also acknowledged that there's an ongoing problem. That does not mean that everyone is getting a treatment what we think is the best. So dealing since a long time with these complex illnesses, but there's definitely a much better focus in some of the countries than in others.
in the UK, I guess is there a difference in Scotland, Ireland versus England in how it's dealt with, or is it the same throughout the UK?
Well, I think, well, first thing, I can speak for Scotland, England, Wales, Northern Ireland, because I treat people from all four of those countries. They come to see me in Dublin, or I run a clinic in Edinburgh, Scotland. And the challenge is that Scotland, you know, if you put Scotland, England, Wales, Northern Ireland together, you've got 60, 70 million people, and they report maybe 1,000 cases a year. And you look at the German statistics with a similar population, and you're dealing with 300,000. And if you look at France, over 70,000, similar population. And I think the issue is nobody's keeping track of how much Lyme cases there are in the UK and Ireland. There is no reporting. And it's very disproportionate to have 1,000 cases when we have very similar populations, probably similar tick burdens in UK and the rest of Europe. But there's huge underreporting. And I do agree it gets back to the very simple concept is if there's a very traditional view of Lyme disease, easy to diagnose, easy to treat. The testing is perfect. And 2 weeks of antibiotics in Ireland is all they recommend as part of treatment. In UK, they're more liberal. They'll give 3 weeks of antibiotics for suspected Lyme with the option to do an additional 3 weeks. But still, education of GPs, they have very little knowledge about Lyme disease. Many cases are being missed. You know, the challenges are pretty huge. You know, there's a huge lack of education. There's a huge lack of recognition of the disease. There's a huge lack of collecting data on cases in the UK and Ireland. And there's a huge downplaying of the severity of Lyme disease. So it's very difficult for patients. And that's why patients leave the, UK and Ireland, and they go to places in Europe or places in America where they'll get appropriate treatment.
Okay, so it's in Asia, it's in South America, it's in Europe, it's in America, it's everywhere.
Yes, but there we should go back to the discussion that we had yesterday. What is Lyme disease? Why do we call it Lyme disease?
Right now, historically, the theory is it began in Lyme, Connecticut, but it seems that's not correct. Okay, you had some historical research
absolutely.
You did. What? And
Yes.
And it didn't begin in America. So it was recognized first where, in Africa or France?
It was recognized. Well, the old case that we have is over 5,300 years old. It was found in the Alps. It was a mummy called Otzi, and her brain was full of Borrelia burgdorferi. Then if we look at the history, we find in 1702, Drury described borreliosis in Central Africa. Then in 1900, it was described in Spain. In 1907, Amédée Borel found it in France. In 1920, Charles Nicolle, Nobel Prize of Medicine, found it in Tunisia. In Congo, 1933, Schels described it in Congo. Let's go to Cape Town, where Palakoff spoke about it in 1944. Kenya, Heish described the disease in 1950 as a relapsing fever. Then the same thing, Helen Sparrow in Ethiopia in 1950 was also talking about the relapsing fever. And then only in 1975, it was described in Connecticut, changing the Borrelia into Lyme, which was actually a village in Connecticut. So Lyme is a village. Lyme is actually not a disease, but now it becomes Lyme and Co., which is not an excuse because it will blind the research for other infectious diseases. So when you find Lyme, when you find a patient that's sick and has no Lyme, in America, I've seen it a lot, they're called Lyme seronegative. No, they've got something else. And co is not strong enough to balance Lyme away for me.
So-
But
so
that's a big
Yeah,
story.
even in America, it wasn't first discovered in Lyme. It was discovered in Milwaukee. It was written up in Milwaukee. Uh,
Dermatologist,
yeah, 1970.
Henty.
Yeah.
Yeah.
So it just the name Lyme stuck because people recognized it. What's a better name for it? Although it's hard. Different
Well,
people call it different things, and I don't know what a good name is. And it's that you have 20 different names floating around.
yeah, my suggestion would be to involve all the obligated intracellular organisms. So those, the Lyme, so-called the borreliosis, the Rickettsia, Mycoplasma, Chlamydia, Toxoplasmos, and all that are intracellular organisms. So they have to live in the endothelial and then in the cell tissue. So I would say that obligated intracellular organism, OIO, is a good name. The problem with Lyme disease here in South Africa, the doctors think that it doesn't exist if you didn't go to America. And in many countries, not only here.
Well, in America, it depends on what state you've been to, what state you come from, and where you've traveled. There are certain states that they don't believe, have it, and that's just not.
Yeah, as I said, it has been discovered all along throughout centuries, not only in America.
I think everywhere but Antarctica, as I remember.
It has been discovered there.
It was okay.
I think maybe near the Straits of Bransfield. Okay, but it's almost followed the course like psychiatry, where I'm looking for my old copy of DSM, and that was the original classification of mental disorders. And it used to be really three things: schizophrenia, psychoneurosis, and organic brain syndrome. And then with time, it got expanded, and now we have the DSM. So there's always a categorization that keeps expanding, and lumpers and splitters. And it's hard when we talk about different things. So we probably need a better organized way of nomenclature that's based on how people think. But I think if you see it as a simple, it can impact how you see it. So you could look also at the clinical presentation. So it is presented sometimes as you have to have a tick that stays there for 24 hours or longer. You have to have a bullseye rash, and it's arthritic. And
which is true.
What's the scope of it? What's the true scope of this disease? How would you describe it?
The germ, as I said yesterday, will not give you its name, but the name of its position in the body. So it does change. One day it's more neurological, the other day it will be rheumatological, then it will attack the heart, it will be digestive, it will be all over the place. You can't put it in one sector. It's not one organ that's affected. It's all of them together, or one after the other one, or mainly in the scar tissue. It's also determined by genes. It's the symptoms varies. That's what the complicated disease. It's a vascular disease, and the vessels you've got from top to got vessels from top to toe, and they live in the blood vessel. There are they travel through the blood vessels, and they go everywhere, and they stay there more and there more and there more. When they're there, you develop epilepsy. When they're somewhere else, you develop psychiatric. And it's the toxins of those germs that give you the symptoms anywhere in your body.
Well, that's, I think, why they say it's the new great imitator, kind of like syphilis was the original great imitator, because you can see anything like it, and I suspect you all have seen various manifestations of every system.
But I think one of the things that pointed out, by calling it Lyme disease, you kind of say you have to be in Old Lyme, Connecticut. You know, you don't really describe the organism. You don't really describe the manifestation of the organism. And, 10 years ago, when I started managing Lyme patients, we didn't think about co-infections much. And now all of a sudden we've tried to change it from Lyme disease to talk about tick-borne infections, because it really is multiple infections that are maybe triggered by Lyme. Lyme is still an important pathogen in all of this, but there's many other reactivation infections that occur, co-infections that occur at the same time as the tick bite. So I just think we're in a better place now, at least in Lyme literate groups. We're really recognizing the co-infections to be very important, not just Lyme. But if you go back to the traditional people in the UK, you have to beg to get a Lyme test. People, the GPs will say there is no Lyme, there are no ticks. The consultants will refuse to do Lyme tests, and they won't even consider doing, Anaplasma rickettsia. You can't get those tests done. And I actually had a recent patient that come over to see me from the UK in Ireland, and they had a bullseye rash, joint pain, classic symptoms, but their Borrelia antibody test was negative, and they were refused treatment. They came to see me, and I repeated the test, and I did anaplasma as well. And he was anaplasma positive. And it was the test that was done for anaplasma was from a UK accredited public health laboratory. So you couldn't deny the value of the test. So he obviously had a tick-borne infection. He had Borrelia plus anaplasma. I treated him, he got better, and I gave him a copy of his anaplasma report and said, take that back to the consultant in the UK, ask them where anaplasma came from. And now does he believe that he had a tick-borne infection? That bullseye rash was Borrelia. So I just think, we've got a long way to go in countries like the UK and Ireland. There's a total denial of Lyme alone and no recognition of tick-borne infections, co-infections. But I think we're better off than we were many years ago. There is recognition in some countries, and it kind of gives hope that, things will improve in the UK and Ireland because, other countries in Europe are doing a better job. America's now doing a better job, I think, as a rule, in keeping track of the epidemiology and maybe being more understanding of chronic symptoms related to Lyme. So I just think, I think, this is a huge challenge for us as clinicians, but it's even more of a challenge for the patients who are not listened to and not treated appropriately.
I think one bias was when it was first researched, early researchers were more predominantly rheumatologists.
Yep.
So they categorized it with what they understood, and it was then categorized more as an arthritic disease rather than viewing it as a multi-system disease, where doctors with that training were less likely to look for the site symptom or that were outside their area of understanding.
Yeah, look, we have also to be careful to call them only tick-borne diseases. So there are a huge number of other vectors which can lead to transmission, and only some certain infectious diseases out of that group needs a tick for transmission. Many of them can be transmitted by normal mosquitoes, by horseflies, by sandflies, by mites, by lices, and so on. And so probably vector-borne diseases would be the better term. Yeah, but vector-borne diseases isn't explaining all the complexity of these infections, causing so much trouble in many organ systems.
Even by this.
I'd like to make the comment that tick-borne illness, or what do you want to call it, tick-borne diseases, Lyme borreliosis complex, we're sort of like the unwanted stepchild in the medical world, where chronic illness is not appreciated, where it's dispensed out of hand, and it's trivialized. I'd like to point out something that everyone already knows, in that of the 20 top non-pulmonary, non-cardiology chronic illnesses, we only know the etiology of two. One is HIV and one is H. pylori. We don't know the cause after how many decades of neurodegenerative disorders, rheumatologic disorders, neuropsychiatric disorders, and all of these things are increasing in great quantity. There's too many cases of ALS in the US. I don't know about the world. There's too many cases of MS. It's gone wild. There's much too much rheumatoid arthritis. So I think we're dealing with a chronic inflammatory state with oxidative stress, which actually depletes key cellular functions and energy, of course. And in the right genetic setting, this sort of chronic oxidative stress will help the illness, whether you call it rheumatoid or whether it's the ALS or whatever, help it to emerge. So there's no question there's genetic heterogeneity here. And there's nothing to compare to the chronic, 24/7 inflammatory process that goes on in these individuals, unless you're dying with AIDS, which very few people, or you're dying with cancer, and those people die. Our people with Lyme borreliosis complex, they want to die, but they can't die. And I've heard that many times. And of course, the leading cause, the last time I checked, of death was suicide. And it's a scandal for our societies around the world to not recognize this. And I think we had the discussion that we're all puppets for the insurance companies, and I can't speak for all the other countries, but we're definitely here, we're puppets. And if you don't conform, then you're singled out and you're criticized. And that's been a lot of my career. I've been in and out of medical boards. I've spent so much money, but I hung in there. And so, because I believe in what I'm doing, and also you get affirmation every single day when you come to the clinic, because people say, thank you for what you're doing. Keep on doing it. I know your whole story, and we're proud of you, and we really, really appreciate you. So that, to me, as a doctor, if you can get more than one patient, 2 patients a week, 3 patients a week, come to you and say that, that's like what other profession offers that opportunity if you've done the right thing and tried and definitely help people, albeit in a unconventional way, if you will. Unconventional from what? Unconventional from mainstream medicine. It's not unconventional. It's listening to the patient, using your medical skills and background and experience, and applying palliative treatment and then hopefully definitive treatment to get this patient in good health, which may take 2 to 3 to 4 years, but it can happen.
What do other
It's
people
actually
feel?
very classical. It's a classical approach. It's not unconventional.
Yes, it
I
is.
know. I'm using their
Yeah.
language,
Yeah.
Celine.
Yeah,
I'm using their
sure.
language.
What's the leading cause of death? And I feel it's suicide, but I'm a psychiatrist, so I see more of those patients. But is there any other feeling about what the leading
Plenty.
cause of death is?
Yes, there is cancer because infected cell will be cloned at the same speed than a normal cell that gives cancer. There's also heart attack. There's, I think heart attack and cancer are the main thing that kills.
Mhm.
Yes, cancer anywhere. Cancer in the brain, cancer digestive, cancer in the lungs, and also the bilharzia that I was talking before takes a lot of importance in those diagnoses. Totally ignored everywhere in the world. And it's growing and growing with the migrants. You find it everywhere. I had a clinic in Germany, in Denmark, and in Belgium. And when I go there, recently, it was this year? Yeah. I find so many people with bilharzia positive. And they never been anywhere else than in Europe. And the bilharzia mimics the cancer totally. It looks like a cancer.
I was thinking about, though, that issue of transmission. We've talked about, vectors, but what about human transmission? I mean, what do people think about congenital tick-borne illness or,
Yeah, of course, through the placenta, of course. But I was thinking of something that we were talking about. How does it become contagious? Well, myself had a big experience. I broke my neck and I had 3 grafts of bones of donors. And after that, I developed the whole the whole type of disease like rickettsia, mycoplasma, chlamydia, Lyme disease, and all that. And it was in the graft because the grafts are kept in freeze, so the germs are still alive in there. And when we were talking yesterday about blood transfusion, it can be, but organ transplant, that's definite. Nobody look before you do a transplant if that organ is infected or not.
Only for certain infectious diseases, not for all of them, unfortunately. That's right. Yeah. But coming back to your question, so I guess without the typical transmission via insect bites or sticking, we have definitely to consider that there are other ways of transmission as well. So I personally do not see any big problem regarding sexual transmission. So we have done a trial after we got notice of Dr. Stricker's study a long time ago in San Francisco, based only on a few couples. We did the same in my former clinic as a multi-center studies with other clinics all over Europe, and in round about 80 couples, we haven't found any evidence. So I personally believe, so I can't rule out that there's sexual transmission, but I personally see that as a very low risk at the moment. And we can't rely on these couple of case studies. So in one case study, they have found in male semen evidence of Borrelia bacteria or spirochetes and out of vaginal lesions as well. But now to transfer that generally that there's a high risk, I guess I can't confirm this from my perspective.
I'd just like to comment on that in that when I was doing HIV/AIDS, there was some data that generated over the years, of course, that said that if you have a gay couple with one patient infected and the other not infected, that the transmission rate was 3+%. It was, and over the years, but the incidence of sexual involvement was much greater for the gay population in general. But if you looked at a heterosexual couple, one of whom was infected, they can have intercourse 100 times over a year and remain negative most of the time until they're not negative. And so if we have frequent encounters with arachnids or we have frequent sexual encounters, I still think, Karsten, that it's possible. Certainly, I think it's, and people ask me in the awkward question about, okay, when can I have sex? And, am I a danger to my husband? Am I a danger to my wife? I say, I don't know. I mean, nobody knows these answers.
It can depend on the stage of the illness. I think Dr. Lambert probably has an opinion with congenital, also breast milk.
Yeah.
I think I'd just like to say that the issue of congenital Lyme, the transmission of Lyme in pregnancy, has been really downplayed, even to the wording. ICD-11 doesn't include congenital Lyme. Lyme is listed in most kind of websites as possible in pregnancy. There is a possibility it could transfer, but they don't come down and say it does transfer. And they don't do any studies to say how commonly does it transfer. We don't know these questions, but can Lyme transfer in pregnancy? Absolutely. If you look at the literature, there's hundreds and hundreds of articles, but when you look at recent publications in the medical literature, they kind of select 15 articles that say it doesn't transmit. They cherry pick. So there's a huge bias, I think, in the medical literature against the concept that Lyme transmits in pregnancy, even though there's abundance of data. And we've actually published, in Dublin here, reviews on this subject, looking at the literature, and there's clear evidence that Lyme transmits in pregnancy. We don't know how commonly. We don't know how commonly it transmits sexually either, because it's even more difficult to do studies, on transmission that's horizontal than transmission that's vertical. If we could do studies in pregnancy with Lyme, we would actually answer the question, but we can't do those prospective studies because there's still no acknowledgement in most, guidelines, most articles that are published that it's even a possibility. It's not even a possibility. It actually is happening. What we don't know is how commonly, because we don't have the science behind us.
It's not uncommon for me to see a child who presents with psychiatric issues and I discover they have tick-borne infections, to then wind up diagnosing one of the parents with having tick-borne infections. And it's very clear in those cases.
I do that
Probably
all
more
the
than
time.
the father.
But also, there are a few studies out that seem to show that this is true can happen with co-infections. And I think that's really important for us to keep in mind. I know there's one talking about congenital transmission of Babesia, and I've seen another one talking about that with Bartonella. So there is so much that we don't know that probably are affecting these kids.
I had one family I followed, and it was 4 generations of transmission of Lyme disease associated with autism as a manifestation.
I would say that.
Yeah.
But if you go to the publication of the 80s with the group of my father and Charlie Cohn and all that, it's clearly published that a lot of miscarriage and all those things are due to rickettsia. There's lots of publication about that, but they forget and they throw away. Yeah, in those days it was common to believe that. Now it's like we rediscover it. No, it's known for 20, 40 years. It's not new. I've got all that literature. It's mainly in French, but there's a lot of, I don't know if you know about Clinique de la Résidence du Parc. So it was a meeting for French, English people once a year, and they would all say that every year. So it was not something special. It was accepted.
Well, in my practice in DC, we have hundreds of families that have been involved, either one or both parents, and family of 3 perhaps, or family of 3 children, maybe 2 are infected and they're worried about the 3rd one.
Absolutely.
We see this, and Rosalie, you know this to be true. I mean, you see it even up more closely than we do, but we see it. I have a pediatric nurse practitioner who will see, and I always tell her, I say, I feel sorry for you because you're treating a difficult patient, a child who isn't interested in being there usually.
Sure.
And you're also treating both parents.
Yeah, it's very common. It's very common to find not one autistic child in a family, but many.
Absolutely.
Mhm. Yes.
Absolutely.
On the other hand, you have also to take in consideration that families are very often living in the same habitat, being exposed to the same risk.
Same
So. To take your children to go to any outdoor activities in the woods, and then everyone is exposed. Yeah. So I don't neglect the congenital transmission. So I've seen plenty of these cases, that's for sure. But so if we have these histories of Lyme, over 1, 2, 3, 4 generations, so probably it's not only a matter of congenital transmission. So
I've got families of motor neuron diseases. The grandfather, the father, the son, the nephew, They all have the same thing. But it doesn't matter. It can be treated. It's not because it's genetic that you have to stop the treatment.
Well, a good example is we take a very thorough history, as most of you do, I'm sure, and that includes parents and their siblings and their grandparents.
Mm-hmm.
And we see a litany of chronic illnesses, which can be debilitating. So, okay, my father had lupus, for example. My mother had rheumatoid arthritis, and we had an uncle who was schizophrenic, and we had a grandfather who had psoriasis and also became dependent, and the grandmother had some kind of colitis, which killed her.
That's the end product, as I said. That's the end product caused by what?
I'm saying I see an association between these conditions and what we consider to be, whatever you want to call it. Okay, it's a chronic inflammatory illness with polymicrobial origins, with multisystemic involvement, multi-compartmental neurologic involvement, and it's never stops. And so, as I said before, I think if you're genetically predisposed to have ulcerative colitis or Crohn's disease, and by the way, we see a lot of patients have comorbidities with Crohn's disease, with rheumatoid arthritis. I've seen them both in the same patient more than once. And guess what? We treat the illness and they get better. We treat the illness. We'll tolerate working with a rheumatologist. No, I shouldn't say tolerate, but we'll work with a rheumatologist as long as the steroid level is not too high. And, you know, we don't want to immunosuppress. No, you have to work with them, okay? You can't just shake your head. You have to work with these people to keep peace. And if the steroid, you accept a certain amount of prednisone, maybe 7 milligrams, 8 milligrams, then you try to taper it. But we've worked with a whole range of individuals who had more than one illness. And once you treat them, you allow them to take what you consider to be only mildly immunogenic or immune-altering medication. No high steroids, no pulse steroids, nothing like that. And you say, okay, let's work with you and let's guide you through this, and let's see if we can get you better. And many times we can get rid of the rheumatoid features for the most part. I saw a young man who's in his 20s now. He wants to be a sports athletic specialist, and he had flexion contractures of his elbows. He couldn't walk. He had spasticity. And after 2 or 3 years, in this case, I just put him on tetracycline for the most part, doxycycline for the most part, after I had treated him. I know. There's a book called The Road Home, and McPherson Adams was at George Washington University. And he wrote in the 80s a book called The Road Home. And he was the chairman of rheumatology. And so he started treating his rheumatoids with tetracycline. And it was a very slow process, but they gradually got better. And he's very discreet with, how he dosed them and all that sort of thing. But I think that's just one tiny facet of the whole world of this tick-borne illness and associated diseases. And I want to make the point again, there's way too much chronic illness in our world. There's way too much. And I think it's fueled by, who knows, it's genetics, it's the environment, it's the food that we eat, and behavior patterns and so forth and so on. So the world is changing in terms of the things we're being fed and what's happening in the environment. There are 1,000 new chemicals put in our environment every year. I don't think that's good for the human condition.
But people also talk about food as medicine, and it really is. If you think about the microbiome and just all of the changes within the body. One of the issues is pathophysiology, which you alluded to, Joe, in terms of the immune dysfunction that causes a lot of these symptoms. But it's not as simple as that, right?
Right.
I mean, there are a variety of different factors that come into play here, because there's a possibility of autoimmunity, although there could be some disagreement about that, as well as a direct infectious process causing problems, because we have seen evidence of Borrelia in some cases of pathology, cerebral pathology.
And we have also taken consideration the environmental influences, the global warming. So, looking back, let's say in Europe, 50 years ago, we haven't had so many ticks spread it all over Germany or in the neighbor countries. So, but with the global warming, having no more winters, so the habitats constantly grow. Yeah, and
one comment about the global warming is that during the time of Louis XIV in France, there was malaria in Paris.
Yeah, now we have several cases around Frankfurt, around Munich, because of the warm conditions. Yeah, so
the cycle is not 20 years, 50 years, but 500 years.
Sure, and this is where we have this big growth of the tick populations all over Europe, and in the ticks, in the microbiome, we are finding more and more different infection. Yeah, this is one of the issues. So for 40 years you haven't had any Babesia in the northern part of Norway or Scandinavia. So that had changed completely. Yeah. Due to the global warming, and this had a huge impact. So definitely, and
not only that, but the population that's moving so fast and all around the world, that's also a big factor.
One thing we all are discovering, I think, is how much environmental factors like mold and fungus play a role. Well, in the United States, at least, in the late 1970s, they passed a law to get rid of lead in paints. Lead is a retardant that will slow mold growth. So once they did that, I think that's part of why we have more of a problem with mold in homes.
Yeah. But I think the whole concept is Lyme is not simply just an infectious disease. And that's that, especially if you catch it late. And most of the patients we see, we are caught late. We don't see them early because the primary care doctors are missing the diagnosis. So we're seeing lots of late cases. But if you actually look at these, these late cases that we're seeing, the challenge is really that this is a complex disease. It's not just the infection, it's inflammation, it's autoimmunity. The patients we see, their lymphocytes are low, their neutrophils are low. These bacteria are immunocompromising these patients. So it's not a simple disease. It's not easy to treat. It's much more complex. And as clinicians who are experienced in managing the complex cases, antibiotics alone don't treat these patients. You need to deal with the immune system. You need to deal with the inflammation. You need to repair the damage. And this, I go back to the day of HIV and AIDS. Back in the day of HIV and AIDS, as there was no treatment, the immune system got lower and lower. They get more and more infections. You treated that infection with antibiotics. They got better. But when you stopped the antibiotics, they deteriorated again because antibiotics alone don't treat an infection. You need a healthy immune system. You need CD4 lymphocytes, cytotoxic T cells working with the antibiotics to cure the infection. And there's a lot of similarities between HIV and AIDS and the immunosuppression, I think, and why patients with Lyme disease don't respond to treatment. They don't respond to antibiotics necessarily because their immune system is deficient, just like back in the day of HIV and AIDS. So I think that really is the challenge of the patients we're seeing. We're seeing the chronic patients, the missed patients, and the treatment is, I agree, molds can cause immunosuppression. But the primary problem is you have an infectious disease. You need to treat with antibiotics, but you need to do all the other things to repair the immune system, to deal with the inflammation, to make sure the antibiotics work, and you can achieve a cure. And that takes longer course treatment, and there is no recognition of this in the general medical community?
I like to phrase complex interactive infection, but it's more than infection. There's all the environmental pieces to it too. And one way to break it down is you have the infection, you have the immune functioning, and then you have the symptoms. Those three different pieces interact, and you can intervene in any of those three areas or all those three areas. But it is, I guess, a lot like HIV, where these patients are immunocompromised in some way. I think you get the infection, and rather than adaptive immunity, people never get adaptive immunity to Lyme, although maybe some people do. All right, but the people we see don't. And that's why they keep getting reinfected. Instead of adaptive immunity, they get persistent inflammation instead of temporary inflammation until you get adaptive immunity. You get persistent inflammation and autoimmunity, but not adaptive immunity.
Well, I just want to say I agree with Jack. As I mentioned briefly the other day, we won't treat a patient until we've done a full evaluation. But more than that, if we do decide to treat the patient, and by the way, having a support person is paramount. We won't treat a patient unless they have a support person that we've interviewed. But the point is to reduce inflammation. You'll be putting things on a more even keel, if you will. And I use the analogy, would you rather go down the tarmac at 180 miles an hour? Or would you rather ride the side of a mountain with no no gates or no barriers? Which one do you want to take? Do you want to stand? Do you want to, if you want to go fast, yeah, pick your route.
Now,